that there's very clear misconception and myths, if you like, about heart disease.
Now it says here, heart disease only affects older people.
Depends. The key thing, though, in that is recognising that younger people still have heart disease.
I'm a bit scared to talk about this one, to be honest. I could almost feel my ancestors rolling in their graves, and even as I'm about to say it, because it's something that is so commonly practiced in some of our cultures. Welcome to Core Magna Heart and Soul, where we dive deep into the topics that matter most to your heart, your health, and well-being. Today, we'll be hearing from our Chief Medical Officer, Dr. Justin Mariani. Justin's a medical doctor and practicing cardiologist, specializing in pacemakers and heart failure. In this episode, Justin and I will be doing a bit of myth busting to dispel some of the most common misconceptions about heart health and heart disease. Hi, Justin. Very nice to have you with us today.
Hi, Amber. Thanks for having me.
So, I've been very excited and very keen to do this myth-busting episode with you, not least because I've fallen victim to some of the myths here. But tell us, Justin, in your many years as a cardiologist, how many times has someone come up to you and say something about heart health or heart disease, a misinterpretation or something that's just flat out wrong?
It's a great question, and it's a very good observation because over time, many people have said to me, both as patients in clinic and socially in other sort of environments, even me just watching TV, that there's very clear misconceptions and myths, if you like, about heart disease. And so with the opportunity to speak one-on-one with patients or families in different environments, I can have a discussion about those specifically. In other environments, it's a bit harder. So it's interesting sort of having the opportunity to perhaps go through some of these heart myths, if you like, and sort of have a discussion about where there might be a misconception or highlighting where a slight deviation to that thought process is important.
Yeah, no, you're absolutely right. And we know, especially because heart disease is the leading cause of death, it is a complex issue. So in a way, I don't blame people for going out there to look for information. But at the same time, there's a lot of misinformation going around as well. Health in the health space just being one of them these days. So, look, I've got a very long list. I mean, we could go on forever, to be honest. But for today's episode, let's just look at some of the more popular ones. Let's call it the top 10. I'll read them out, and you tell us, Justin, what you think is the right thing. Are you ready?
Sounds like a good plan.
Great. Okay, so let's start with myth number 1, and this is probably the most common one. Now it says here, heart disease only affects older people. Justin.
Heart disease only affecting older people is certainly, from a population viewpoint, older people are more likely to have heart disease, and whether it is actually something that leads to their untimely demise or as the terminal event, if you like, depends. And the majority of people, over 70 or 80 will have a form of it. The key thing, though, in that is recognising that younger people still have heart disease.
Yes.
And so that's one of the common myths, that if you're not focusing on heart disease as a younger person, you're missing opportunities to improve risk factor management, to sort out symptoms that may be life-threatening, and also to make sure that you're keeping a very healthy heart in terms of focus, because the changes you make at a younger age are those that then translate to improvements over time for older, when you're an older person. Certainly we know that younger people who start exercising and looking after themselves in their 30s, 40s and 50s will do better in the long term. Doesn't mean that if you're 60, 70 or 80 and developing heart disease that it's not the opportunity to start looking after yourself.
That's a very good point, yes.
But the key thing is to recognise that both younger people can have heart disease, and it presents in different ways. But there are different types of heart disease that can affect younger people as well that perhaps older people don't get. Certainly genetic types of conditions, things that are running in families or that people are born with, they will affect younger people, and they can manifest or turn up when someone's very young or in their 20s or 30s or 40s. But it may be that it's a very different type of disease problem. So being aware that these things can occur is important. Certainly, we would always recommend that where a family member has something that looks like it runs in the family, that younger members start looking at it, what's what we call screening, and there may be specific tests. There might be blood tests looking for cholesterol, or echocardiograms looking for thickened heart walls, or looking for enlarged aortas. All of these things can still occur in younger people, and often with a genetic link. And then there are other things that can occur in younger people that are often very commonly seen, including heart rhythm problems and what have you. So in any clinic that I would have, the majority of people are going to be over 50, but occasionally we see younger people.
Right.
So it's important to recognise that heart disease can occur in younger people as well.
Great. So it's not just, to be very, very clear, it's not just a disease that affects older people. It can affect people who are much younger. Now, I think it's probably a good opportunity here to share with our audience that firstly, if you're aged 45 and above, you can go to your local GP and ask for a Medicare-supported heart health check. And if you're from the members of our First Nations community, you can also do the same. It's also supported by Medicare if you're age 30 and above. Now, that's the screening I think you're talking about,
Yeah,
Justin.
absolutely.
But I think the other important point you're also mentioning is that even if you may not have hit those age groups, and even if you're not, let's say, 50 or 60 or 70 and above, even if you're younger, but you are aware, for instance, that, for whatever other reason, for family reasons, you might have inherited certain genes or lifestyle, some of these things can also put you at risk of developing heart disease. So it's not a bad idea to go and have a screen, go and have a chat with your GP, just to see if you do need to do that heart screening anyway. Would you agree with that, Justin?
I would agree. Yeah.
Okay, right. So that's one we've got out. So number 2. Now this is really good because I've actually heard this one myself from friends and family members. So let's see what the audience thinks. If I have high blood pressure or high cholesterol, I'll know it. Of course I'll know it. I'll feel it. Justin?
So that's a very common misconception. And there's a couple of reasons for it. If we just focus on high blood pressure. So people are very aware that if your blood pressure is low, you may feel dizzy occasionally. And if your blood pressure is very high, you may have things like headaches and eye issues. But for the majority of people who sit with high blood pressure, and we'll focus on that because that's the risk factor, high blood pressure may sit between numbers, and we're going to use numbers here, like 140 millimetres of mercury, systolic blood pressure up to 200 with no symptoms. And it can be running at that level for a very long time. So in feeling that, in thinking that that's actually a risk, because you're not feeling it and so you're ignoring it.
Yes.
That's a very common misconception. So one important aspect with blood pressure monitoring is just actually checking it. Now there's a lot of data that shows that patients and people who check their blood pressures by themselves do better than those who don't.
Yes,
now being very compulsive about it's a bit different, but certainly we know if you're keeping an eye on your blood pressure, we know that, and you know that your blood pressure is sitting 120, 130, like a healthy blood pressure, that you'll do better. And it's an awareness of that, but you won't feel it.
Yes, and I think that's really the important message out here. So everyone out there, now if the message here is that we won't necessarily feel it as part of our everyday life if we have high blood pressure or high cholesterol. These are risk factors or issues that actually require scientific medical tests. So no, that's not true. If you have high blood pressure or high cholesterol, you might not know it. And the best thing to do, again, is to have a chat with your GP, go for regular checkups to see that everything's under control and as it should be. So thank you very much. Let's move on. We've got quite a few. I love this category, Justin, because it's, again, something that, particularly among the younger age group, I think this happens quite a bit. Now, let's see what we think. Athletes don't get heart disease. So I exercise all the time. I'm very fit. I'll never be at risk of heart disease. What do we think about that?
So that's a very common misconception, and there's a few reasons for that. One is that society looks at athletes as being the pinnacle of physical physical appearance, physical health.
Fitness, yes.
Fitness. Well, fitness can be defined in many ways, but when you look at athletes and then sort of, everyone moves down from international to local sport and just doing a park run on the weekend. Yes. Being fit and healthy is a very good sign and something to be achieved, and something that people should try and achieve. Yes. The issue, though, from an athlete saying, I'm fit, I'm an athlete, I can't possibly have heart disease, is a very clear misconception for a variety of reasons. But the main one is that a lot of other conditions underlying it, genetic risk, for example, high blood pressure they weren't aware of, cholesterol they weren't aware of, can still be bubbling away in the background, leading to disease that can then cause a problem. Now, the one thing that's important here is that often athletes do better than if they weren't athletes. So say if someone's taking a pathway in life and you've got the fit family member and the not fit family member and they're both running with similar genetics, the fit person's probably going to do better than the not fit one. Okay, yes. And so this is actually a very important thing. So being athletic, being fit is good for you, but it doesn't necessarily mean you won't have heart disease or are immune from developing it. So athletes themselves and anyone who's fit needs to be keeping an eye on their heart health. Now, one thing we do know is that people who are fitter and more invested in their health usually do better than those that aren't. And so we see this aspect that the person who's very lifestyle focused and health focused is often fitter and looking after their health, and they probably will do better. But it doesn't mean they're immune.
Yes, so the key message here is that it doesn't discount the possibility of developing heart disease, although you're probably on a better track than compared to someone who doesn't do any exercise at all. I think we can all accept that.
Absolutely.
All right, great. Now, again, this one, I've actually been asked this question before by a family member. A strong heart means a low resting heart rate. So if I've got a very low resting heart rate, I must be in the clear, and that must be better.
So the low heart rate myth is an interesting one. And I guess there's a few issues here, one of which would be even my own bias. I'm actually a pacemaker specialist as well as a heart failure specialist. So I see people with low heart rates.
Yes.
And often this discussion of my heart rate's always been 40, I feel fine. And yet they're starting to have symptoms and passing out and what have you. Now, that may be a different issue at play, but in the advent of smartwatches and alerts coming in with heart rates under 40, we're seeing a lot of people turning up who are otherwise fit and well, who can run 10 kilometres and no issue, have got a low heart rate. Yeah. Now, the one thing with that group is the low heart rate probably is good, but there's other groups where the low heart rate is not good. It could be indicative of electrical problems in their heart that need further management or over-treatment with certain medications that may be leading to a lower heart rate. So although a lower heart rate may indicate a fit person when that person is actually exercising a lot, it doesn't always mean it. So if someone has a low heart rate out of the blue, it's probably not a good thing. Right. If someone is very fit and has a low heart rate, it's probably okay. Yeah. But also people who are very fit can still have a relatively high heart rate. Yes. And it doesn't actually mean they're not fit, and it doesn't mean that they're at higher risk. And that's also a very important takeaway.
Yes. So then I think a very important message here is that things have to be understood in their context.
Absolutely.
So we can't look at one aspect or just one particular data, one particular point of reference, and draw a conclusion from there. We've got to see whether or not the heart rate is because they exercise all the time, and we hear this quite a lot, that people who do 10K runs, 3 times a week, they tend to have a lower heart rate than others. Or if it's because you don't exercise, but you chronically have, heart rates in the 40s anyway, and you're starting to feel a little faint, a little dizzy, slightly unwell, that's a really different situation.
It is a different situation, and there are certainly lots of things that can contribute. So the one aspect is, again, if there's a change, to see the GP to have a discussion about other factors that may be in play. When you're unwell, your heart rate goes up. When you're well, it may come down. If your thyroid's off, it may go up and down. So things external to what the heart does also can affect it. And so it's an important aspect that, yes, having a low heart rate can often, in the right person, indicate a degree of heart health, but not always.
Not always. The next two are on medication. So big one, and very important to get this right. And again, this one is something that's quite close to me because I've got several family members actually on this very common medication. Let's talk about statins. And I think many people will be very familiar with statins. Now, the first thing here about statins. Statins cause unbearable muscle pain for everyone. I don't want to live with that. I'll deal with my condition, my cholesterol by myself. I'd rather have that because I don't want to risk having unbearable muscle pain. I've got a list of things to do every day. I'm a busy person. I don't want to take statins. That's tricky, isn't it?
Well, look, statins are a very common medication, almost to the extent that about 50% of the adult population is on a statin, and it's probably the same as having fluoride in the water. For a population that is at risk of developing atherosclerotic disease, statins are very useful. Now, going back to an earlier myth about, we talked about blood pressure. Yeah. Cholesterol's the same. Yeah. You'll never feel high cholesterol. Well, I lie. There are some situations where very high cholesterol can cause issues, but for the most part, it's not something people feel. You don't know if your cholesterol's 7 or your bad cholesterol LDL is 5. People don't feel it. It's a risk factor for developing disease. Once the disease manifests, someone may have a heart attack, then you'll feel it. So until that point, you don't feel it. And so the only thing you can really track is the blood test, and a belief that taking that statin will keep your cholesterol down, coupled with healthy eating and lifestyle and what have you. Right. But having statins is problematic because there's a subgroup of patients, a reasonably large one, about 5 to 10%, who will develop what are called myalgias. Now, myalgias, everyone's had myalgia. A myalgia effectively is that all over body ache you have when you got the flu. And with statins, primarily it affects the large muscles of the legs and sometimes other parts, but people just feel achy. Where it's unbearable that a patient starts a statin, then just gets the muscle aches and has to stop it again, that's about 5 to 10% of patients. And it really depends on that person's perspective on whether they want to push through it and minimise their risk, or they just can't bear with it, in which case there are other options. One is a lower dose of statin or taken every few days under the supervision of your doctor or your cardiologist. At the same time, there are other medications, so ezetimibe is one example. Even injectables in certain situations can help get your cholesterol down. But we see it too often that statins cause issues, and then coupled with that is the belief that statins themselves cause other issues, for example, brain-related problems, in which case someone will stop their statin and they expose themselves to significant risk and then will have a heart attack in a few years' time. And I've seen that in my career many times. We all have as cardiologists, and it's very upsetting to see someone who was on treatment, had a period of time in their life where maybe they had some muscle aches, maybe they saw something on TV or Facebook and decided to stop the statin, and then a few years later turn up with a heart attack. So when those issues occur, when those, and it's actually true. So when those issues occur, we do try and work out where the issue is and try to correct it for the patient. It's a very common myth, and one that we spend a lot of time with our patients in clinic discussing. Yeah. At a societal level, there's a lot of misconception about it, and unfortunately, the echo chamber that occurs when people say, stop the statin, everyone stop the statin, it becomes an issue. Don't stop your statin if you can avoid it. Right. Speak to your doctor.
One person says it starts, that gets the ball rolling and the myth gets bigger and bigger.
Absolutely.
So 2 really important messages here about statins. Number 1, it's not true that it'll definitely affect everyone or 100% of the people who are taking statins. It affects a subgroup of people, as Justin's mentioned, about 5 to 10%. And even in that situation, have a chat with your cardiologist, your doctor, if you feel you're starting to experience these symptoms from statins, because even then, there are other management plans that you can take in collaboration with your cardiologist, with your doctor, to consider alternative medication, or changing the dose. There's more likely than not that there is something that you can do. Don't make that decision by yourself to either not take statins completely or to stop taking statins when you start to feel these muscle aches. The next myth: I feel fine now And so I think I'll stop taking my medication. I don't think I need to see the doctor about this because I feel good.
Again, a very common scenario in clinical practice, and we see it more often than we'd like to see it. It is a bit troubling, and there are sometimes reasons, and I understand that. But it goes back to a very simple thing, which is that when you feel better, you don't feel like you need to be treated. And we all have antibiotics, as an example, for short periods of time. Take it for a week, you're better, whatever you're fine. And yet the prescriptions for cardiac medications in particular, blood pressure tablets, statins, aspirin for risk or after a stent, heart failure therapy, medications for arrhythmias, they can last forever. We're not necessarily curing the condition, we're suppressing it and we're treating it long term so that it comes under control and doesn't manifest. So where occasionally we have these issues is someone feels better and they stop their tablets. We see it a lot. And in specialist medicine, the difficulty is we don't see the patient necessarily. We give the advice, they go back to their GP, they get lost to follow up, and then all of a sudden something manifests. Their blood pressures become an issue, their cholesterol's become an issue, they've turned up and had a heart attack. And so that's a concern. And how we best manage that is difficult. Certainly part of it's education, recognising that for longevity, for a good outcome, to suppress worsening and sort of stepwise deterioration, that medication continue, because the cessation, stopping it, is not so beneficial to most people. So it is a very common myth. Now, there are situations, and this is actually important, that, for example, a heart rhythm issue may be treated, medication can stop, patient feels better, that's probably fine. But discuss it with the doctor who's actually prescribed it for you, because what we then look for is when an issue may turn up, when we would act again, when we may think about another treatment. Certainly same with other conditions, say high blood pressure, where someone, as a lifestyle intervention, someone was morbidly overweight, lost 20 or 30 kilograms, and their blood pressure is better all of a sudden. They don't need to be on treatment, but they may actually need to be having ongoing monitoring and to restart early enough. So that's important to recognise. Statins, we don't tend to see that very often, because once your cholesterol's high, unless your diet was pretty terrible, most people, their cholesterol's still high. If they're at risk, they should just stay on a statin. So there are certain situations where we would see that taking it off is okay, but it should be discussed with someone first who can then talk about what to look for and where it might be appropriate. But the majority of medications, we would say, don't stop.
Yeah. So, I mean, it's really important, again, this brings us back to understanding things in context, right? So we know, for instance, that heart disease, they are varied and they're different and they're often quite complex. Quite often as well, they can be accompanied by other comorbidities. So it really depends on what disease and what medication actually that you're on, because you might actually be feeling better because you've been taking the medication. So then deciding on your own to come off the medication may not be such a good idea. Now, as Justin's very helpfully mentioned, there are some instances where coming off medication can be a good next step, but there are some instances where coming off medication may not be a good idea, particularly because we know that in some cases for the different types of heart diseases that we have, they're not necessarily curable, but they are most definitely manageable with the right medication, the right lifestyle changes, and doing things differently, and more importantly, having the right network of support, including with your GP and your cardiologist, to have a chat about the proper next step, even if you're starting to feel better. So the key takeaway here is don't make that decision by yourself. It's best to understand things in context and to have a chat with your doctor on whether or not you should stop or continue with these medications.
Well summarised. Well summarised.
Right. So now I'm a bit scared to talk about this one, to be honest, but I was going through this last night. I could almost feel my ancestors rolling in their graves, and I can feel now that my right eyelid is throbbing even as I'm about to say it, because it's something that is so commonly practiced in some of our cultures. And but I think it's so important that we discuss it, because that's the point where we learn new things. If you don't talk about it, you'll never learn new things. So I'm just gonna say it.
Yep.
Coconut oil is plant-based and therefore it must be good for you. It's heart healthy. There's nothing wrong with it. There, I've said it.
Okay, so I come from a culture where coconut oil is perhaps not a staple, and so it's easier for me to perhaps say that sentence. But I promise I wasn't teasing when I wrote it. But
No, and we've had this conversation before, yes.
No. So coconut oil, of course, is very high in saturated fat.
Yes.
And so the idea that everything that is plant-based is healthy is actually slightly erroneous. Now, although a vegetarian diet is probably healthier than a non-vegetarian diet,
in terms of the reduction in
absolutely, from a heart health perspective,
yes, in terms of excluding red meats,
and I have to be very careful with this. I don't want to be cancelled by
my
meat-eating friends, but we have to be realistic about this. That saturated fat is generally bad for you. Certainly, if it's in a high intake aspect, but where there's a cultural staple, certainly in countries where there's a lot of saturated fat that may be part of the meal, there's a concern. Yes. Now, trying to re-educate culturally is difficult, but it's just important to recognise that. Now, the beauty of living in a country like Australia is that people have an ability to mix and match different types.
Oh, absolutely. We eat different things every day. Yes.
So, for fantastic. Me, I love, for example, eating Malaysian and Singaporean type food because I just love it. Even if there are aspects that I don't know actually what
goes into it. And we're lucky because we've got so many things to choose from. Good choices here.
My surname's very Italian, and so I'm mindful of having grown up with Mediterranean food, and so it's an easy sell when the data supports very clearly that a Mediterranean diet, which really is read as olive oil and lots of vegetables and what have you, is the key aspect to it. So we know that certain types of fats are good for you. The unsaturated fats, they're very good for you. We prescribe fish oil tablets to people and other types of fats. So certain fats are good. It's a high intake of saturated fats that's a concern. And that really comes from eating meat and dairy and certain other aspects. But the important aspect is trying to have a balanced diet.
Of course.
But the myth here is that all plant-based diets are healthy.
Or that coconut oil particularly.
Well, exactly right. So the take-home is that having a plant-based or vegetarian diet is generally good for you, and that shouldn't be taken away, but it's not a panacea to heart health care because there are certain aspects where there is saturated fat in it. But everything has to be balanced and taken in moderation. I think that's important.
Yes, and of course we know as well that making sweeping statements is never good anyway. No. And it's not necessarily this type of diet or that type of diet because everyone is different really biologically, despite many genetic similarities that we may share ethnically or by way of family. But some people, might react differently to different types of food, whether it's plant-based or whether it's mixed or whether it's more meat-based. And the key, again, really is to, do things in moderation, I suppose, have a balanced diet. Check with your doctors, make sure, you're not allergic to anything. But making broad sweeping statements about, cultural types of diet, identifying them by culture, or that this one thing is definitely bad, this one thing is definitely good, without really understanding the nuances and its impact on our individual bodies. That's really the danger, isn't it?
Well, it is. And certainly this is a whole other area of discussion because there's so much research coming into it now. Well, it is because, we know from research that the Mediterranean diet, when tested in Mediterranean countries, patients who take that after having had a heart attack do better than those who don't have the Mediterranean diet. But it's a diet that's very high in olive oil or in nuts, for example. But can that data from that group be transplanted in Southeast Asia? Yeah. I don't think so.
No, and we've got very good examples. For instance, we know that the people in the Japanese culture, they're famous for a very healthy, for longevity. It's something to think about. Right. So we've talked about heart disease being something that only affects older people, and we know that's not true. We've talked about whether or not people should decide by themselves to get off medication. That's not true. We've also touched a little bit about low heart rate, exercise, as well as coconut oil and whether or not that's healthy. But guess what? I've got one that I remember reading in my early 20s. I shouldn't say how long ago, about red wine. So, here we go. Red wine is good for my heart, so I should drink it daily.
That's a very common myth,
I wish that was true.
and I think a lot of people do. And I won't say I'm one of them, but let's just say that the cardiologist's choice of wine tends to be Pinot Noir.
Is it? Good to know.
But the myth, perhaps to an extent, is one that's still in a degree of development, although I don't think anyone is actually recommending that red wine or alcohol of any nature is something that has a medicinal purpose. Now, we know over centuries that doctors have been very much a part of the alcohol and winemaking industry. There's certainly in Australia, we have a lot of wineries that were founded by doctors.
Right, well, I didn't know that.
Speaking to their medicinal purposes. And it may have spoken to other issues. Certainly at a time when, pre-refrigeration, maintaining food had to be perhaps coupled with a bit of alcohol. I don't know. But nowadays, with data coming through, the concept that alcohol is good for you is being debunked. The question then of whether some alcohol is good for you or at least not bad for you is a more important one. And that's where the myth sits somewhere in a degree of equipoise, if you like. So I think most people would recognise that living well and enjoying life involves good food and wine. It's a very cultural thing. And if you're going to do it, red wine is probably better. There's also the myth aspect of what the French paradox is. And I think everyone's heard about the French paradox where the French, who love their cheese, who love their wine, who smoke more than other Europeans, have a lower heart risk than other countries. But the difference between, say, the French and Australia, or French and the Americans, is that where 50 to 70% of Australians would be considered overweight by BMI, in the French it's 10%. So the French paradox may actually be explained by other factors, weight being the big one, as opposed to how much wine they drink. But to an extent, drinking red wine every day is a myth. It's not good for you. Drinking some is probably okay, and it's probably a question that needs to be revisited down the track.
Yeah, but the key takeaway here for red wine is that blanket statement that red wine is good for my heart, so I should drink it daily, is something that's a myth. Yeah,
and to be very clear with this, I don't want misconception sort of carrying on from me being a little bit ambivalent or not perhaps being very clear. There are very certain conditions in cardiology, heart failure being one of them, where alcohol is contraindicated, where atrial fibrillation is another, where alcohol, certainly in higher amounts, is seen to be contributing to the condition, and we recommend patients coming off it. And certainly patients who have high blood pressure are likely to have higher blood pressure drinking alcohol than not, and so the recommendation is to decrease alcohol. So there are very few very few conditions in cardiology where we would say drink alcohol, it's good for you. It's a question of do you remove it entirely and be abstinent? Certain conditions, yes, but for everybody else, it's still something open for debate.
The jury's still out.
The jury's still out.
Oh, yep. Okay. Well, then the next category of questions is something that I think is particularly relevant given the advancements of technology and, of course, with AI and wearables, consumables, personalized medicine and things like that. But these two, I think, are particularly relevant to our discussion concerning heart health and heart disease. Let's talk about this. If my smartwatch ECG is normal, well, that means my heart must be healthy.
That's a very common misconception and one that I think needs to be debunked, because as cardiologists, we see that all the time. And the ECG is the big one here, because the smartwatches, to an extent, can capture ECG, an actual ECG. Yes. Put your finger on it, and you've got an ECG coming
Which, in
through,
a way, it's very impressive.
Which is incredibly impressive
Yes.
technology. Certainly for the masses, but it's certainly very limited, and we can't rely entirely on it. So as cardiologists, many of us are seeing in our clinics groups of patients turning up who are otherwise well, who are being identified as maybe having a problem by something sitting on their smartwatch, and at the same time those who have conditions where the smartwatch is missing it. And we're doing clinical trials in our own institution at the moment looking at the accuracy and reliability of it because it's not answered yet. But in saying that, certainly some of the smartwatches can pick up ECGs. They're approved at a regulatory level for doing that.
Yes, they are.
Which means that there's a belief that they must be right. And this goes back to the next point, which is that you can't necessarily rely on the test. There are sensitivity issues. Does it pick up the condition? There's specificity issues. What does it actually look at? And so recognising that with smartwatches and then giving it to people who aren't professionals and interpreting the data, the general public with a smartwatch, has opened an entire can of worms. And this myth then that having a normal heartbeat with a smartwatch means that everything is good, and at the same time identifying people who don't have a problem because something turns up on a smartwatch. So there's going to be a real move in the next 5 to 10 years, and I think we're all seeing that, where both the technology itself plus coupling that with the advancements in AI, interpreting that data, will mean that we start having better information. But how to interpret something, again, means you need a health professional to help recognise whether that might be an issue or not. And with symptoms, of course. It goes back to the previous discussion where we talked about low heart rates being a normal finding. If someone has a low heart rate and feels completely normal, then that's very different to someone who has a low heart rate and is feeling awful. It may actually be indicating that there's a problem.
So again, I think it comes back to this theme here where we shouldn't be looking at individual data points in isolation, and having just the one ECG reading from a smartwatch may not always tell us the complete picture about your heart health. So again, of course, I'm not suggesting that everyone just go and start swamping your local GPs if you're feeling absolutely fine and there are no indications, no other risk factors at all. But particularly if you're starting to feel a little unwell, and there are recurrent events, then don't just rely on the one data point from a smartwatch.
Yeah.
The best thing to do is always to go and consult your local GP and if necessary, speak to a cardiologist.
So it has to be taken in context, and that level of interpretation of the result needs to be done with a health professional who's trained in looking at results. At the same time, there are other things that we can also look at to try and determine if a low heart rate or some other heart rate variability issue turning up on their smartwatch is true, because there are other tests that are perhaps a bit more accurate that can give some feedback as to what we're actually really seeing.
Yeah. Well, that's very good to know. I mean, I'm wearing a smartwatch. You're wearing. I don't know anyone actually in my circle of friends these days who hasn't got at least one smartwatch or some kind of fancy consumer device, and that's definitely a good thing. I think we're moving in the right direction, but then also having to be mindful of taking all these singular data points in isolation and not really understanding them in context. So thank you for that. Well, this is another one. Is more self-monitoring always better?
How are we defining self-monitoring?
Well, that's a good question. That's probably something we should explore.
So from the older way of thinking about self-monitoring, the days before smartwatches, self-monitoring may have been recommending to someone buying a blood pressure cuff, seeing their GP once or twice a year for a cholesterol check and other blood tests, keeping an eye on their weight on a regular basis, monitoring what they do. That's self-monitoring in a very simple way. And surprisingly, a lot of people never do that. Don't see a GP, don't check their blood pressure, have no idea of those parts of their body, even if they know those parts of their house and those parts of their car and those parts of their financial statement.
Right.
They just don't self-monitor their health.
Yeah.
What comes through now, of course, is self-monitoring with smartwatches.
Yes.
So that gives a little bit more. But the question then is it beneficial to be self-monitoring all the time more than not? So this is really important, because some people over-monitor and some people under-monitor, and there needs to be a Goldilocks area in between, and it's very person-specific, so that you know what you're doing, because monitoring too much can lead to issues such as anxiety.
Definitely.
And we see that quite a bit, that I have patients who will monitor their blood pressure 3 to 5 times per day
When they don't have to.
when they don't have
It's not
to.
been prescribed.
Absolutely, and
Yeah.
misinterpret what those numbers may mean and get really stressed out about it. And a lot of the time is educating them and their families about where we worry about blood pressure ranges and the variability. So lots of monitoring is actually good to talk to a patient then about the education of variability over time. Different times of the day or their hydration status will mean that their blood pressure changes. But again, different types of monitoring is good. Now, there are disease states, for example, heart failure, where we do ask patients to monitor regularly. Those patients do better.
Yes.
So someone who is who has heart failure may need to fluid restrict. They monitor their fluid intake. They also monitor their fluid intake by their weight on a daily basis. They're monitoring their need for medications and what food they ate. Those patients actually do better than not. But for the general question that self-monitoring is better,
As a blanket statement.
as a blanket statement, I don't think that's the case.
Yeah, because then that in turn can lead to other mental health issues. I mean, you don't want to end up feeling unnecessarily stressed or anxious about something that you didn't have to worry about, and you don't want to lose sleep about it literally, and you don't want to sort of get your blood pressure up, you don't want to, get headaches because you're stressed, and you don't want to be doing that.
No.
So if you are required or prescribed to do self-monitoring because of a particular condition that you have, for example, you mentioned heart failure being a very good example, and I actually know people who have to do this, and they do it well, some do it better than others, admittedly, then please do that and do that, conscientiously. But if you don't have to do it, it's not been prescribed, or you don't really have an underlying condition that's been confirmed, then it's probably best not to be checking things 3, 5, 10 times a day.
I agree.
Yeah. This has been incredibly eye-opening, at least for myself. I hope for the audience, for the viewers, I hope you have found this helpful. But if there was one thing, I suppose, Justin, that you'd like our viewers to take away from this myth-busting that we've been doing, what would that be?
Firstly, I think is to understand the role that health professionals can give in terms of answers, and not to be lost in the world of Dr. Google and the echo chamber that comes through social media. I can see where the issue can occur, and often without someone to be able to speak to and to rationalise the concerns or test results, it can be difficult.
Yes.
And we're facing issues with our healthcare system. It's harder to get
Because some
in.
people do feel isolated.
Oh,
Some
absolutely.
people feel quite lost. They want to do something about their condition. And it's very common these days, not just in healthcare, but in many aspects of our lives, that we just go onto the laptop or our phone these days, and we just look on the internet. Is it this? Is it that? Can I do this? Should I do that? I want to find out more about this. And so in a way, it's understandable. But
Well, one thing, and to make the point so that it's not misinterpreted, is that there are fantastic resources online and often great groups to jump on board with. Someone has an issue and they may find that there are others online who have a similar issue. But that can go down a bit of a rabbit hole in certain situations. And again, I've seen all sorts of different things being presented to me which lead to things like non-compliance and not taking medications because they saw someone say that online. So it goes back to the point that, ask the health professional, get some feedback from them first.
Well, that's I suppose the key point here really, because we're talking about myth busting, and we're not saying don't look for information elsewhere. We're saying yes, it's great to be proactive and
Absolutely.
to care about your health and to want to be on top of things and to want to get more information. So then the key question becomes, where are the reliable sources of information that we should be looking to?
That's a fantastic question. So there are lots of resources available, and I guess it's something that if you have access to the internet, people can go looking for these things. So the first one is national foundations that are set up within someone's country. So, for example, in Australia, the National Heart Foundation of Australia is a fantastic resource. The Cardiac Society of Australia and New Zealand would give excellent resources, and there are disease-specific areas as well. The Better Health Channel and other internet sites that are run by governments also have information that's vetted and appropriate. Now, I recognise that some people may not want to go to those websites, so they go looking somewhere else.
Yeah.
There are certain web add-ons that can be placed on your internet search engine that has what's called the HON code. So Health Online code, I think it is, HON code. And what if it's a reputable website that's giving reputable type information, that will highlight as positive that that's a reputable website to look at.
Right. Well, that's a very useful piece of information. That's a very practical tip for what our viewers and our members of audience can actually look out for the next time they're looking for something on the internet. So there we are. We've covered a lot of ground today. We've talked about lots of myths and done quite a bit of myth busting, where hopefully we've dispelled many of the misconceptions surrounding heart health and heart disease. Justin, I want to thank you very much for your time with us today. I hope you've had some fun doing this today.
I have, Amber. Thank you very much for having involved me.
Thank you so much to all of you listening and watching this video. I hope you found it helpful. See you next time.